Are we live?
Yes, sir.
Yeah, thank you. A very good evening to all. My name is Sanjay Prakash. I am the Regional Business Manager with Pfizer. On behalf of Pfizer, I take this opportunity to welcome today's esteemed faculty members led by Dr. Kripa Bajaj ma'am and the expert panel members for this very important meeting on the topic treatment benefit of the CDK4/6 inhibitors in hormone receptor positive and HER2 negative metastatic breast cancers, from clinical trials to the real world setting. As you all know, the treatment landscape of metastatic breast cancer has witnessed a profound advancements and progressively witnessed a rapid change in the last few years or maybe a decade or so. Several therapeutic strategies have proved that the capability of prolonging the survival of the patients with MBC. The incorporation of the CDK4/6 inhibitors in the treatment armamentarium of the CDK4/6 in hormone receptor for positive HER2 negative metastatic breast cancer has shown a major advancements. Today, to discuss more on this topic, we have the esteemed faculty members, Dr. Kripa Bajaj ma'am, and the expert panel members, Dr. Rajni Priya ma'am and Dr. Pradeep sir. On behalf of Pfizer, I welcome you also. It's a privilege to introduce the moderator today. Dr. Kripa Bajaj ma'am is a consultant medical oncologist at Basavatarakam Indo-American Cancer Hospital and Research Institute at Hyderabad. And ma'am is joined with two expert panel members, Dr. Rajani Priya ma'am, who is a consultant medical oncologist at Mahatma Gandhi Cancer Hospital, Vishakhapatnam, and Dr. Pradeep sir, who is an assistant professor of medical oncology at Homi Baba Cancer Hospital, uh, which is an attachment of Tata Memorial Hospital. Welcome to all the expert panel members, and I also welcome the healthcare professionals who have connected to us virtually this evening for this important meeting. With this, I request Kripa Bajaj ma'am to take over the proceedings of the meeting.
First of all, I thank Pfizer for giving this opportunity to interact with the my esteemed panelists, my very own colleague in TMH, Dr. Pradeep Ventrapati, as well as Dr. Rajni Priya. So today we are going to discuss regarding CDK4/6 inhibitors. So the palbociclib, all of us know the Paloma update was discussed in ASCO 2022. What are the intricacies of the result and why it should not be practiced, like in certain pitfalls and setbacks are there while interpreting the data. So, and what is the opinion regarding those pitfalls from my panelist? So what is the treatment benefit of CDK4/6 inhibitor in HR positive, HER2 negative advanced breast cancer in clinical trials and the real world? So all of us know the standard of care for HR positive, HER2 negative advanced breast cancer, that's a metastatic breast cancer, is a CDK4/6 inhibitor in the first line, be it a low burden of disease, be it a high burden of disease. Across all the guidelines, NCCN, ESMO, as well as Advanced Breast Cancer 5 guidelines suggest that implementation of CDK4/6 inhibitors early in the management of the metastatic breast cancer will improve the PFS as well as OS with a good toxicity profile with preserved quality of life. So this is agreed across. Even aBC 5 strongly suggests that the combination of CDK4/6 inhibitors with endocrine therapy is the current standard of care for patients with ER positive HER2 aBC because it achieved a substantial PFS benefit, significantly increased OS benefit, either maintains or improves quality of life. So all guidelines agree with the management of breast cancer with CDK4 inhibitors and hormone therapy combination right from the first line, irrespective of the disease burden. So CDK4/6 inhibitors extends PFS and OS in RCTs in patients with HR positive, HER2 negative MBC. As all of us know, the three key players of CDK4/6 inhibitors in the market is palbociclib, ribociclib, and abemaciclib. The respective trials, the Paloma trial, Monarch trial, Mona Lisa trial, all the three three drug combinations, it has shown substantial improvement in the PFS as well as OS. But Paloma, there is the recent update which happened. There is a OS benefit is like not seen, but we will discuss the setbacks. But if you see all the trials across all the trials, there is a significant PFS benefit without any doubt. OS, some difference is there because of that varied data, but there is a OS benefit as well as noted. And polypharmacology of FDA-approved CDK4/6 inhibitor. If you see the three drugs have a different mechanism of action. This is like, though it is CDK4, but certain selectivity of CDK4 CDK is there for three different drugs. So let us see the ASCO 2022 update. So by and large, all of us agree with that. The three CDK4/6 inhibitors are having a different efficacy, different outcomes across all the trials. It has shown different updates, has shown different benefit. Ribociclib recent update OS benefit is there, but Paloma update there is no OS benefit is there. Abemaciclib adjuvant setting there is a benefit got noted, and abemaciclib efficacy there is a good data is there. But if you see the population subgroup which got included, the varied population in the within the each trial, we can't really take those trials really into the to practice certain aspects. So coming to the OS update, the overall survival with first line palbociclib plus letrozole, that's pal plus let, versus placebo plus letrozole in HR positive, HER2 negative advanced breast cancer analysis, Paloma 2. What is the background? So palbociclib is the first CDK4 inhibitor. All of us know it got introduced in 2015. And this Paloma 2 trial, it's a randomized trial which has shown a significant and clinically meaningful improvement in primary endpoint of PFS. After median follow-up of 23 months, the median PFS was 24.8 months with a palbociclib plus letrozole versus 14.5 months with the placebo plus letrozole. At the time of final PFS analysis, OS data was not matured then. Final OS analysis was performed of required events were reached by November 2021 with a median follow-up of 90 months. So the results of final OS analysis are reported recently. So if you see the Paloma trial, it's a very well conducted trial. Only postmenopausal women got included in this one, and no prior treatment for advanced disease. See, that's a first line therapy with letrozole, I mean to say, with the preserved ECOG status. The randomization happened to palbo plus letrozole versus placebo plus letrozole. The primary endpoint is PFS. Secondary endpoints are overall survival, response rate, safety, as well as PRO. The stratification factors are based on the disease site, that's a visceral, non-visceral, disease-free interval, that's a de novo metastatic, less than 12 months of hormone failure, or more than 12 months of hormone failure. That's a primary versus secondary, and endocrine resistance, prior neoadjuvant hormone therapy, yes or no. So these are the stratification factors when assessing one. The statistical assumption for PFS as primary endpoint. Sample size determined to date 44% improvement in median PFS from 9 months for the control arm to 13 months for the palbociclib arm, assuming a true hazard ratio of 0.6 in favor of palbociclib arm, with the power of 94% with alpha of 0.025. So the statistical secondary endpoint is like overall survival, assumption for a control arm median OS of 34 to 46 months. If you see the primary endpoint PFS, the updated analysis has shown with a significant PFS benefit, that is 27.6 months with palbo plus letrozole. The hazard ratio is 0.56. So 27.6 months versus 14.5 months, there is a stark difference in the PFS got noted. And if you see the demographics and baseline, there are very well balanced beta age, ECOG status, beta disease type, and disease-free intervals, prior endocrine therapy, prior systemic therapy. And survival disposition, the intention to treat population is 66% due to consent withdrawn and 34% the overall survival analysis which were present as for 2022. Absolutely, there is no difference with hazard ratio 0.956, 53.9 versus 51.2. Why is it so? If you see the ECOG 0 subgroup, it has a maximum disproportion missing data between two arms. Letrozole arm performance is unprecedented. So ECOG 0 status data, there is a lot of survival data is missing in it. So maybe this altered the data outcome. The subgroups with the least disproportion missing data, the 1-2. So 1-2 disease interval more than 12 months, prior endocrine therapy, all these kind of subgroups, they are with the least disproportion missing data. But ECOG 0 status, there is a significant missing data, is there almost 13%, which altered the outcome. So the post hoc sensitive analysis, excluding patient with survival data not available, again they did the patients, they excluded the data of the patients whose data is like not available. They excluded those kind of population and further analyzed it. So then they found the further numerical OS improvement favoring palbociclib combination therapy, indicating the impact of missing data. If you see the post hoc sensitive analysis, it is 51.6 versus 44.6 months OS difference is there, with a hazard ratio of 0.89, which is very significant. And Paloma 1 and Paloma 2, the combined OS analysis, if you see, all patients, the median OS is 51.8 months versus 46.8 months. The hazard ratio is not so significant, that's 0.934. But if you see the subgroup of patients with DFI more than 12 months, it is 64 versus 44.6 months, with a significant hazard ratio of 0.736. Post-study systemic therapies, endocrine therapy, chemotherapy, CDK4 and mTOR inhibitor, patient who discontinued study treatment, all these like were both are very well balanced in both the subsets. If you see the CDK4/6 inhibitor palbociclib, the time to chemotherapy is significantly better, that is 38.1 months versus 29.8 months, with hazard ratio of 0.73. So CDK4/6 inhibitors, when the comparison was done, the first line postmenopausal females, Paloma 2, Monarch 3, Mona Lisa 2. So if you see the less than 12 months disease-free interval versus more than 12 months disease-free interval, so there is a Paloma 2 is the only one like which has included that both less than 12 months as well as more than 12 months. Here Monarch 3, it is not so staunch, and Mona Lisa 2, if you see less than 12 months, not much, only one person is the sample size. So Paloma 2 is including heterogeneous population where the disease-free interval is only less than 12 months, almost 22% is there, and more than 12 months, 40% is there. So whatever population there in the Monarch 3 as well as Mona Lisa 2, it is not exactly like similar like a Paloma 2. There, the most of the patients have a good biology disease with more than 12 months, but here both less than 12 months got included. The both bad biology and poor biology patients as well as good biology patient got included. Hence, the results are altered. So the population is heterogeneous. We can't expect the same OS benefit like other Mona Lisa 2 and Monarch 3, which recently got updated with a good OS benefit. So we have to note that ECOG status 1 data is like significantly missing, as well as if you see the disease-free interval of patient who got like more than 12 months disease-free interval, those patients got a significant improvement. So it is so heterogeneous to comment upon which one drug is efficacious over other drug based on this data. So more endocrine sensitive population, more than 50% in all Mona Lisa trials. If you see the Mona Lisa trials, like the recent ribociclib update has shown good OS benefit. If you see endocrine sensitive population are significantly included in all Mona Lisa trial. Monarch trial, like Monarch trial is like different entity. Monarch 3 also got excluded that entity, the endocrine resistant population. But all Mona Lisa population like having a very minimal patients who are having the endocrine resistant one. But more of us endocrine sensitive population is there in all the trials, the ribociclib and abemaciclib. Whereas palbociclib, it is like more of a mixed population, both endocrine resistant as sensitive. So now coming to the discussion questions of discussing this, Dr. Pradeep, what do you think about Paloma 2 subgroup results for patient with DFI more than 12 months? So what all I elaborated just now, the patient who got a DFI more than 12 months, like the prior who got treated, the who got a DFI more than 12 months, those patients got a significant benefit with the palbociclib with a good OS benefit. What is your comment on this one?
Yeah, so I agree with what you have said. So definitely in endocrine sensitive setting, like when the DFA is more than 12 months, palbociclib definitely has a benefit there. Okay, but probably in the endocrine resistant setting, maybe there may not be an overall survival benefit, and that is why the results of the overall results of Paloma 2 have not shown quite a significant survival benefit because of this subset of population.
Okay. Dr. Rajni, what's your take on that one? What do you think about the subset analysis of Paloma group, which is having a DFA more than 12 months?
So already you have clearly elaborated. why there is a difference in the overall survival across all the key players. So definitely in our practice also, for patients who are having a DFA of less than 12 months, or the primary endocrine resistant patients, they do not do well with the endocrine therapies with or without CDK4/6 inhibitors. And in my practice, still for the primary endocrine resistance, I usually prefer going with the chemotherapy. So it's mainly because of the more number of patients, that is 22% of the patients, which you have clearly shown in your slides, with a DFA of less than 12 months, which is more in the Palomar 2, might have resulted in a lack of overall survival benefit. So still endocrine resistant patients, I think maybe that is the reason why there is lack of survival benefit with this palbociclib. But
so you conclude that in endocrine resistant population, definitely CDK4 inhibitor should not be offered. Better to go for a chemotherapy than offering palbociclib without no OS benefit. That's your take. That's your conclusion.
Not like in my practice, that is what I follow. Still, I'm somehow not like convinced with the use of CDK4/6 inhibitors with hormonal therapy in endocrine resistant patients. That's it.
Dr. Pradeep, what is your management aspect or opinion about primary endocrine resistant population? So do you think like primary endocrine resistant population significantly hampered the OS benefit in Paloma 2 trial? Right? That's what your conclusion.
No, I'm not saying that is the reason, but that may be one of the reasons. Okay,
it's a patient
that may be one of the
selection.
reasons. Also, there is a lot of missing data. We don't know what treatment was offered after progression on palbociclib or on the experiment on the standard arm of AI. We don't know what treatments have been offered also. No? So that is why we cannot exactly pinpoint that this is the reason, but this may be one of the reasons why there is a difference between trials. Yeah.
Okay.
Patient
well
selection
taken.
is what made the difference.
Okay. Points well taken. So, Dr. Pradeep, again for you, do you agree that 22% of endocrine population has impacted the overall survival in Palomar? Already you answered this one. And what percentage of patients in your clinical practice have DFL less than 12 months and more than 12 months? Means primary endocrine resistant, how many patients if you see on the set of 100 metastatic breast cancer patients?
Okay, so if you ask, so I will say they will be in the minority. Okay,
Yes.
so majority will be endocrine sensitive. We'll see a minority of the population, probably maybe 20-30%. Maybe the number may be different, but that is what I see in routine practice.
Okay. So
yes, even I agree with Dr. Pradeep Babu. The percentage is very less, like hardly 10% of the population have primary endocrine resistant population.
Dr. Rajani, have you ever tried CDK4/6 inhibitors in endocrine resistant population, the primary endocrine resistant population?
That's what I'm saying. And actually, my experience with the CDK4/6 inhibitor is also like very less. And whatever experience I have with the CDK4/6 is with the palbociclib. It's mainly because of the PAP program given by Pfizer. So, most of the times I'm more inclined to start the patients on chemotherapy. It's not that it doesn't work, but in visual crisis and primary endocrine resistance, maybe I'm more inclined in going for chemotherapy rather than going for these hormonal therapies and CDK4/6 inhibitors.
Okay, points well taken. Dr. Pradeep, what's your clinical experience of CDK4/6 inhibitor in your endocrine resistant patients?
Yeah, so if endocrine resistant or sensitive, if they are not in crisis, our first option is to give CDK4/6 inhibitor. Okay, and some of them do well. Until now, probably I think the response to CDK4 inhibitors was less only in the endocrine resistance population. Probably I think I had 3 or 4 patients, who have progressed only within 3 or 4 months of therapy of CDK4/6 inhibitors who are endocrine resistant. But most of the sensitive patients have actually done well, more than 1 year.
So here I wanted to add, it's not for the all endocrine resistant population I'm speaking. It's a primary endocrine resistance. For the secondary endocrine resistance and endocrine sensitive patients, obviously I'll avoid chemotherapy. I'm just saying the primary endocrine resistance subset of patients, to be clear.
Okay, And just now, both of you mentioned that like two significant points must have hampered the effect of palbociclib is OS difference is got affected by disproportionate missing survival data, and PFS benefit between DFA less than 12 months versus more than 12 months similar and significant. But OS like got hampered because of the significant survival data. And we can't say because PFS got noted even the primary endocrine resistant population, the OS must have been hampered because of the missing survival data. That's what the conclusion of post-hoc sensitive analysis. Because if you see this less than the primary endocrine resistant population, the PFS got preserved. And again, if you see the OS analysis, it is not there. It's not the similar thing. So they comment that the OS difference must have been because of the missing survival data, which we also have to relook upon. And what is an acceptable loss to follow up or missing survival data in clinical trials? I just want to comment on this one. In RCTs, typically investigating drugs or therapies, it has been suggested that a loss to follow up of up to more than 20% poses serious threats to the validity of data, and even more than 10% may pose bias in the statistical analysis. Paloma 2 had a disproportionate loss to follow up or missing survival data between the Ibrance treatment arm and control arm, that is 13% versus 21%. So like two arms, like significant data missing is in the control arm 21% as well as treatment of 13%, which is really significant. If you see, it's one is more than 20%, one is more than 10%. So this must have significantly affected the data. So discussion questions are impact of missing survival data. What impact of loss to follow up in both treatment arms do you see on overall survival result? Dr. Pradeep, the question is for you.
I'm sorry, can you repeat the question?
So what impact of loss to follow-up data in the both treatment arms do you see on overall survival result? So 21% in the control arm and 13% in the treatment arm. Do you think it's really significantly will impact the data analysis?
Definitely it will impact. Results? Yeah, definitely it will impact. We don't know what happened to those 21% patients, and also we don't know what those 13% patients have been taking afterwards. So definitely it will have a significant impact.
Dr. Rajni, what do you think? Is it really a huge impact on the analysis? 21% and 13% missing data?
Yeah, probably could be one of the reasons.
Okay. So clinical trial endpoint for tumor with the PPS more than 12 months. It's a National Cancer Institute Breast Cancer Steering Committee working group report on meaningful and appropriate endpoints for clinical trials in metastatic breast cancer. If you see this, working group consensus on preferred endpoints by biological subtype and line of therapy, the hypothetical scenarios for expected post-progression survival, and choice of preferred endpoint. So post-progression survival is very important. That's one of the meaningful survival endpoint. In settings such as HR positive, HER2 negative aBC, given the expected long post-progression survival, PFS is the most appropriate endpoint. So post-progression survival is like very important, and PFS may be the most appropriate endpoint, not just the OS. That's what National Cancer and Breast Cancer Steering Committee suggested. So it's not only OS, PFS is also very good because PPFS is a very significant one, which is missing in like huge data subset what we mentioned before. Because PFS is decent enough, we can take that up as a very good endpoint. So discussion questions, clinical trial endpoint for tumor with post-progression survival more than 12 months. Considering Paloma 2 data readouts and their limitations, do you consider OS a class effect for all CDK4 inhibitor? If not, why? Dr. Rajni, can you please answer to this question?
So actually, though I don't think there is a much difference like between palbociclib and abemaciclib. Both can be interchangeable. It depends on like the experience you have with the drug. So I'm more comfortable with palbociclib. Ribociclib, though it has overall survival data, palbociclib is like one pill per day. So the dose is still tolerable. Hardly I find any patients where we require any where there is discontinuations or dose reductions. So if I have like almost like 8 to 10 patients like from my NIMS experience and here in my practice. So only for one patient I had dose reductions 75 mg. So rest all tolerated well. So just like talking about the overall survival data, we should not should not consider palbociclib because it's not having overall survival. It's not so. So I think either palbociclib or ribociclib we can use. Abemaciclib, I really don't have any experience with abemaciclib. So if I'm given a chance, like which one to choose, so it all depends on your experience with the use of the drug, your convenience, and patients explain the benefit to the patient, and after discussion with the patient, we will go and consider. So I don't think like there is much difference as such.
Okay. Dr. Pradeep, what's your take on this question?
Yeah, so I agree with Dr. Rajini. So it's probably a class effect of the drugs. Okay, so survival is because of the class effect of the drug. And see, if you look at the PFS data, almost it is similar for in all the trials, right?
Yes.
But we are not finding the OS difference. So that obviously doesn't mean that the drug is not working or something. I feel it may be because of other reasons. So I think we can use all CDK4/6 inhibitors interchangeably, and just not rely on a particular OS data for a particular trial.
It's just like even the meta-analysis have shown to have survival benefit. So we may not like
Correct.
just like reject a drug that doesn't have overall survival benefit. So we should not use this in practice. It's not like that. It's having a good PFS benefit, and you have a heterogeneous population of patients. So that may be the reason for the difference in this overall survival and all. So that should not be taken as an important endpoint and not to be practiced in.
Yes.
Okay.
Yes.
So one common question I just want to ask all of you: what is your selection of CDK4/6 inhibitor? What makes you to select one CDK4/6 inhibitor over the other? When will you choose palbo? When you choose ribo? When you choose abemaciclib? Dr. Pradeep?
Yeah. So there is no particular reason, but especially if the patient has cardiac comorbidities, I'll think about avoiding ribociclib. Otherwise, for me, palbo or abema both can be used interchangeably. And abema, if the patient is affording, then probably abema is also an option. But palbo has the best patient access program, right, as of now. So always, so most of the patients I prefer palbociclib.
Okay. Abemaciclib, like what's your experience, Pradeep? Is it easy drug to use or no? So Rajani
So I
has
have
no
used
experience,
abema.
not much experience. That's why.
No, I used only in 4 patients for abemaciclib, and so 2 of the patients did not have any problem at all, and 1 patient had continuous, complaint of diarrhea. But that is also managed with anti-motility agents. But otherwise, all of them are doing well currently. Yeah.
Okay. So in which patients selected ribociclib?
No, ribociclib, I don't use ribociclib. Actually, I have used only for 1 patient. So almost all 30-40 patients are palbo only.
Okay, sure. Dr. Rajani, you have a robust experience with palbociclib, but not with other CDK4/6 inhibitors, right?
Yes, ma'am.
You never used abemaciclib, like you are not
No,
comfortable
never
using that.
used. Never, not comfortable like, but I'm not because like it's costly and somehow I have more experience with palbociclib, so I'm more like inclined to go for the palbociclib. So once in a while, like I tried for 1 or 2 patients with ribociclib, but abemaciclib never I tried. So as Pradeep was saying, so in patients with cardiac comorbidities, maybe I will try to prefer palbociclib. Or else, because my experience with the palbociclib will go for palbociclib. The other thing is like the ease of convenience for the ribociclib is dose reductions. So you can easily reduce the dose, like you can avoid 1 tablet in case a patient is not tolerating or any side effects. But palbociclib, I really faced difficulty with 1 patient. So, like, how do you manage, ma'am? Like, we had started with 125. The patient is not tolerating or having the cytopenias after 1 week. So, how do you go with like taking the drug on alternate day or giving 5 days in a week and stopping? Because they buy the drug and
yeah, correct. That's what I do follow what you rightly suggested. So I do wait like till the count recovery. Once the count got recovered, I do start slowly with the alternative because once patient bought the drug, it's almost 21 tablets will be there. So 2 weeks will be left.
Costly also. Yes, that's
Yeah. So I do try alternate day management. I do see how the patient is tolerating. I do 1 week off later. And the next cycle, maybe I procure 100 mg instead of 125 mg.
Yes.
If patient is tolerating well, in spite of alternate day, it's hardly like, in spite of that, patient is having a significant side effects, then I better use letrozole for some time, later reintroduce like with low dose after some time, like 100 mg.
Okay.
And I do see the correct the baseline nutrition and everything properly. So in spite of that patient is having neutropenia, then it is significantly intolerable. I do have one patient who is taking 100 mg alternate day for 3 weeks, 1 week off. That's her tolerable dose. So now each patient is not similar. So I mean, I do manage like what you rightly suggested.
Go with the alternate day on this.
Yes, yes.
So, did you see any of your patient having like increased serum creatinine with the use of palbociclib? Ma'am, I have one patient like she's having like rising serum creatinine levels, and they're concerned like, is it because of the drug that the serum creatinine levels are increasing?
I don't have any patient who is having a rise in serum creatinine because of palbociclib. I mean, none of the abemaciclib has the tendency to. There is a slight rise in serum creatinine, but palbo really will not cause. Such
That's what
effect.
I was like reassuring them, but they were so much concerned. It's because of the drug only the creatinine levels are shooting up. Okay, ma'am. Thank you.
Okay, what about primary endocrine resistant, Rajini? If you told abemaciclib you will not use. I mean, you haven't.
Yeah,
used
abemaciclib has data with the primary endocrine resistance as well, but somehow maybe I should try the CDK4/6 in the primary endocrine resistant patients, as we have a very few number of patients where we come across these primary endocrine resistant. So this time, I'm more inclined for chemotherapy. Right from our NIMS, we had the teaching for primary endocrine resistance. It's always better go for chemotherapy. But now, as the data is emerging, even with the primary endocrine resistant population, also like with abemaciclib, maybe we can try the CDK4/6 inhibitors along with the hormonal therapy in these patients. But for secondary endocrine resistance and sensitive, obviously they are the drug of choice.
Okay, good. Pradeep, you chose 2 patients abemaciclib, right? Are they both the primary endocrine resistant population?
No. They are all endocrine sensitive patients.
Okay. What made you choose abema over palbociclib?
Yeah, I wanted to see. I mean, just for patient experience. So we wanted to see if it's how it's going to be different.
What about significant visceral burden, like having a impending visceral crisis patients? Do you use any CDK4 inhibitor or you go for chemotherapy? Right Choice study has shown even patient who is having a significant
visceral crisis and impending visceral crisis. I will definitely go for chemotherapy. Yeah, even impending visceral crisis also we prefer chemotherapy. Problem is, there is a risk of loss to follow up. If the patient doesn't come immediately and then she progresses, then we lose that window period. So that's why I'm a little bit skeptical of the follow-up of our patients.
Okay. Rajini, what is your opinion? Like, there is a data emerging use of CDK4 right choice study, right? So what is your opinion? Will you, are you comfortable using CDK4 inhibitor in patients who are having a visceral crisis and impending visceral crisis?
No, ma'am, not as of now. We need more robust data to show that these CDK4/6 inhibitors do work in patients with visceral crisis. Still, in patients who present with visceral crisis, I'm more inclined to give chemotherapy because we need immediate symptomatic improvement in these patients.
Okay.
It is actually safe to use chemotherapy.
Yes. Though the responses are
safe to use chemotherapy. Yeah. So it is risky. No, I'm just saying. So if the patient is in crisis and we give CDK4/6 inhibitor, but by chance she does not respond, so we'll lose that window period. That is why. So it's safe to give chemotherapy, bring the patient disease burden down, and then shift to hormonal therapy if required.
Yes,
have you used only hormone therapy?
I think abemaciclib is having data in visceral crisis also, or only just mere presence of visceral metastasis?
No, abemaciclib is ribociclib is having a better data than abemaciclib for visceral crisis.
Ribociclib is still under trials. I think Right Choice
Right Choice study, like there is interim analysis has shown a benefit. Abemaciclib significant visceral burden, there is an outcome is there. In that one, like there is no active visceral crisis present. It's a significant visceral disease. There is a data.
Yes, ma'am. So still we have to follow the guidelines and still we have to go with the chemotherapy is what I think as of now. Maybe in future, if we have robust data, we can practice using these drugs in visceral crisis also.
Have you used a single hormone therapy, like without using CDK4 inhibitor first line for suppose patient having a few skeletal metastases or few liver lesions, performance is absolutely fine. Will you use single agent hormone therapy? Will you offer a CDK4 inhibitor to them also, Dr. Pradeep?
No. So you're asking my choice or what we are doing
your
currently?
Choice, like for suppose one patient got walked in, like who is having only 3 or 4 skeletal lesions, she's having a slight bone pain. So for such low symptom, low burden disease also, would you like to offer CDK4 inhibitor or not?
Yes, we would like to offer.
Rajani, what about you? Will you use single agent or you want to use combination?
Actually, if you see the subgroup analysis, ma'am, patients with bone only metastasis, there is no much benefit with the use of your CDK4/6 inhibitors compared to your AI alone. So maybe these patients do not really benefit from. They bone only metastasis. Maybe they are good subset of patients who do well even with hormonal therapy, that is AI alone. So maybe like their financial constraints, maybe I'll not push the patients for CDK4/6 inhibitors and reassure them, okay, you'll be doing good even with the use of only these hormonal agents alone.
So in few bone only lesions, there is a
yeah, but not for visual mets. Visual mets definitely we have to go
with
for
any
the
financial
combination.
constraints. That was the question.
Financial constraints, but even if you see the subgroup analysis, bone only, if you can see all the trials, bone only metastasis, there is no much benefit with the addition of.
There is a benefit on PFS basis, but OS benefit is not significant, as Dr. Rajani rightly suggested. In bone only metastasis, also the PFS benefit is like almost like extra additional 8 to 10 months, but OS absolutely no difference in that.
I remember. Okay. I remember there's no much difference in the.
No. For bone only, there's a PFS benefit is there. But if you see the OS, there is no difference. Even the ribociclib OS analysis also, the OS benefit is not so significant in bone only met, but PFS is significant.
Okay.
But like rightly, like our teacher usually, Dr. Sudeep sir usually suggests only letrozole or something single agent when the patient is having a few bone lesions and he wants to switch over second line with combination of CDK4 inhibitor. So we do see really a good PFS in that. But ribociclib update, there is no difference in OS at all, but there was a difference in PFS then. So there is a very good discussion happened.
No, the question is, Dr. Krupa, so you are saying if patient is totally affordable and has no issues, and still you won't advise for combination in those patients? You won't offer combination?
We'll offer combination.
I do suggest combination only most of the times.
We'll offer combination.
Sorry?
That's what we offer combination to all patients.
Yeah, we do offer combination to most patients, but usually like very few metastases. For suppose patients on tamoxifen who progress with 1 or 2 skeletal lesions, it's very usual for us to see Sudeep sir offering only letrozole or something, just switching one to other. Whenever patient hasn't responded, like it's really wonderful to see 2 years or 3 years upon changing hormone therapy in few bone lesions. Once the patient hasn't responded to progress, then only he usually suggest CDK4 inhibitors in such population. But trial has shown there is no OS benefit in such population as well by, actively introducing CDK4 into the first line itself. But PFS benefit is definitely there. So, Pradeep, am I clear? I mean, you're not convinced with my thing, or you want to ask?
No. I just wanted to know what your opinion is. That's it. I'm not.
I do offer, but
at least we can reassure patients who cannot afford, like no issues. Even this works well because you only few skeletal mets. You will benefit
because
this hormonal
there is no overall survival benefit also, right? In the entire trial.
Yeah. But if affordable, obviously we'll go for combination.
Yes. Perfectly correct. So thanks for the wonderful discussion. And the conclusions of today's session is Paloma-2 met its primary endpoint of improving PFS and other secondary endpoints. The overall response rate of 55.3% in palbo plus letrozole versus 44.4% with placebo plus letrozole is seen in patients with measurable disease. The safety profile of palbo plus letrozole remains consistent with long-term use without evidence of cumulative toxicity. The quality of life was very well maintained. OS was numerically longer in palbo plus letrozole arm versus placebo plus letrozole arm, but the results were not statistically significant. The median survival of over 50 months in this population represents a significant improvement in the natural history of HR-positive breast cancer. This is highlighted in the subgroups of patients with DFI more than 12 months, with a median OS of 66 months. 10% of patients continue on palbo plus letrozole in study after 7.5 years of follow-up, which is very good thing to be noted. Interpretation of OS in Paloma 2 is limited by the large and disproportionate percentage of patients with missing survival data between treatment arms. So the ESMO breast cancer 2022 P-reality, I'm not going to too much into the real world propensity score matching and everything, because already we have quite a few discussion on this one. But the real world, I just want to mention some certain points here. So ESMO breast 2022, the P-reality X, a retrospective observation analysis of electronic health records using patient data from Flatiron Health Analytic Database. The size of database is robust, reflects experience across clinical settings, single common data set with a systematic approach to data extraction. So here the objective is, the method is retrospective cohort analysis of electronic health records with US Flatiron, as already mentioned. It is to evaluate the effectiveness of first-line palbo plus AA as compared with ALN patients with HR positive, HER2 negative MBC treated in real world practices in the United States. The conclusion of this P-reality X is palbociclib has significant benefit in patients who used in real world data as well. The inverse probable treatment weight as a propensity matching, score matching was done. These are the statistical techniques to address inherited bias in non-randomized trials. So the baseline characteristics are absolutely fine. And the overall survival before and after, like SIPTW and PSM, it is like significant. The OS benefit is there. The median OS benefit in both inverse probability of treatment weighing analysis as well as propensity score matching analysis like was noted. So the conclusion is median OS was significantly longer among patients who received palbociclib plus AA versus AA alone before and after this adjustment. So I'm not going again to detail across all the age groups, apart from the brain metastasis, other metastasis patients having a significant benefit of the addition of palbociclib. So this is a real world data of evidence of PFS as well as OS. So the conclusions are in P-reality X real world study, palbo plus AA is more effective than AA alone in a heterogeneous population of patients with HR positive, HER2 negative MBC and among various patient subgroups. This evidence supports the use of palbo in common with AA as a standard of care for first-line treatment of patients with HR positive, HER2 negative MBC. So again, the real-world data play an increasingly important role in the expanding use of already approved medication. All of us are really keen on real-world data because the trial setting is different. When it applies real-world, it's entirely different. So the approval is based on data from electronic health records and post-marketing reports of the real-world use of brands in male patients sourced from 3 databases: that's IQVIA, the insurance, Flatiron Health, Health Breast Cancer Database, Pfizer Global Safety Database. So the discussion question here is, considering the wealth of data for CDK4 inhibitor across RCTs and real-world evidence, do you think that there would be any change in the treatment practice amongst CDK4 inhibitors? If yes, then all patients are restricted to certain patient subgroup. Pradeep, the question is up to you.
So, can you summarize the question?
No, so we have seen by P real world X data, by some certain adjustments, there is significant OS benefit also got noted. So both in RCT as well as real world data, there is a good treatment change is there with the additional CDK4 inhibitor. So if you really think, if it really changed, then all patients are restricted to certain patient subgroup. So already we discussed before, which subgroup do you think they got a good benefit?
I'll prefer for all subgroups.
All subgroups, yes. Rightly we discussed just before now. So share attributes of palbociclib from your clinical point: efficacy, safety, and monitoring. Rajani, you already mentioned everything. So you are happy with the efficacy of palbociclib and safety of palbociclib, be it toxicity monitoring also. Are you comfortable, Rajani?
Yes. Usually, like I have one patient who almost completed 4 years of palbociclib. So she's really doing good. Even stopped. I think like we monitor patients only in the first few months, like 4 to 6 months, after which I stopped monitoring also with counts and everything. So it's well taught for patients. When we come to a particular dose, okay, this patient is tolerating this 120 mg or 100 mg. After like 4 to 6 months, we can stop monitoring the patients also. They do well. So palbociclib efficacy, we are happy. Safety wise, we are even convinced. So the only issue I would like to discuss here is like, what is your take on continuing these palbociclibs beyond progression? So if the patient
there is a
on like
data for
palbociclib,
maintain trial. Ribociclib is
yes,
there.
ribociclib,
Very
yes.
the maintain trial is there. Actually, you know, like this usually we used to practice. Ribociclib or any CDK4 inhibitor will have that PAP. So once there is some oligo progression, not a frank progression, for suppose few new lesions are there, we used to switch that hormone combination. If suppose letrozole we are using, we just change it to fulvestrant. So we continue CDK4 inhibitor because they already got must have used like that 8 months or 10 months, whatever duration of purchase they have to do, they finished it.
Yeah.
So we just used to continue because like anyway they're going to get it free. What's wrong like continuing it because they're not having any significant toxicities. So we used to see patients doing quite well on combination further. The maintain trial ribociclib recent data has shown that we are glad that we used it prior the same way. So yeah, palbo there is no data, but definitely we can implicate the data of ribociclib to other CDK4 inhibitors.
Yes.
Yeah. So these are like from different centers of India, all have shown like a very good, decent toxicity profile as well as really good benefit with the significant PFS benefit. Even the first line and second line, there is a good benefit is there across like Bangalore, Jaipur, Hyderabad, and Delhi. Ashok White sir has like single center study Delhi. He recently presented. Everyone has shown a good response result PFS. So and this is the one consensus. Practical consensus recommendation regarding the use of hormone therapy in metastatic breast cancer. In patients with metastatic breast cancer, available evidence does not support local regional treatment. The decision should be individualized based on patient and tumor characteristics, site and number of metastases, and response to systemic therapy. Endocrine therapy rather than chemotherapy is preferred in HR positive MBC. Obviously, chemotherapy may offer for those with highly symptomatic and visceral crisis needing rapid tumor response. A combination of A and palbociclib should be the preferred first-line hormone therapy for HR positive metastatic breast cancer. Premenopausal women need to undergo ovarian ablation before starting A with palbociclib. If treatment with palbo is not feasible, A should be offered. In patients with bone-only disease, fulvestrant may be offered over AI. So there is some like this steroid kind of aromatase inhibitors are better. Like it was like there is some data is there. So maybe in bone disease, like fulvestrant should be offered upfront. So that was the question, but most of the times we don't do that because fulvestrant is quite costly compared to letrozole, and DSM-1 testing is not recommended routinely. A combination of fulvestrant plus palbociclib should be offered to patients who have progressed on AA. Exemestane plus everolimus is another option. So this is the consensus across all the country. All senior medical oncologists have sat and concluded that. And the summary.
I have another doubt. So for patients with bone marrow involvement and cytopenias at presentation, so what do we take it like? Do we take it as like crisis?
Bone marrow involvement, like the problem is the cytopenias. Like we have one patient who was on palbociclib. We thought it is palbo-induced cytopenias. When it got wrong, we did like significant marrow-mets got noted. But when baseline marrow-mets are there, we should not take it as a crisis. We can't even pitch in chemotherapy, or we can't pitch in like really CDK4 inhibitors also aggressively.
Can you prefer abemaciclib in these patients?
Usually we try to mellow down the level 1 reduction of CDK4 inhibitor. I mean, depend on the patient profile. Bone marrow, we can't push really abema because it has its own toxicity. Ribopalbo, I think better because abema, it can cause significant toxicities also. And it's not an easy drug to handle like other CDK4 inhibitors.
Okay. So you go with
level 1 reduction. Yeah, level 1 reduction. I mean, I do start with palbo 100 mg because everything should not, sum up to lead to more cytopenia. So I do start with low dose, and I do see monitor for 1 week whether it's improving or declining. I will see. If it is improving, we'll continue slowly and escalate step by step. But definitely chemotherapy will not be a better option over CDK4 inhibitor and AIs or fulvestrant, because chemotherapy will itself will cause a lot of toxicity.
So you prefer going with a lower dose of CDK4/6 inhibitors only?
Yes.
Okay.
And the summary is all of the CDK4/6 inhibitors pivotal trials were designed to demonstrate a benefit in the primary endpoint of PFS. PFS is the acceptable accepted primary endpoint in metastatic breast cancer by regulatory authorities around the world. Increasing evidence is available for RCTs demonstrating longer OS with the CDK4 inhibitor plus ET was ET alone for HR positive advanced breast cancer. However, the difference in OS was not statistically significant for palbociclib. Real world evidence of associated OS benefit for patients treated with palbociclib combination therapy in first line can help inform treatment decisions in clinical practice. According to worldwide guidelines, CDK4 inhibitors in combination with ET are the standard of care for patients with HR positive, HER2 negative, advanced or metastatic breast cancer. With this, I conclude the session. Any more discussions my panelists want to offer or want to ask?
Yeah, so I just want to ask your experience. Like, did you have any serious toxicity with palbociclib for any patient?
No, only cytopenias I do see. Not see. It's a grade 2 toxicity I do see. Most of the patients I offer palbociclib are elderly people. So elderly people like usually 100 mg more. I do say 50% people will be on 100 mg only eventually. So instead of the corrections and everything, the counts should drop to 1300, WBC to 1300, 1600. Though they're not symptomatic for that neutropenia, but the counts are like really alarming to me. So I do keep on 100 mg. Like and I do keep a very low threshold to switch over to 100 mg. Other than cytopenias, I never had any significant toxicity with palbociclib.
So I had one patient of on palbociclib who had pneumonitis and she expired last year. Yeah, just today when I was leaving the hospital, there is another patient who again came with sudden onset severe SOB, and so again on HRCT thorax there were bilateral consolidation versus pneumonitis query. So I just wanted to know if you had any patients of pneumonitis.
I think it's very rare. I think other infective causes need to be looked on rather than drug induced.
Yeah,
I don't have any experience regarding pneumonitis induced by CDK4 inhibitors. Yeah.
So what is like ribociclib? Can we go start? Are you convinced with starting lower doses like 400 mg?
So there is a trial going on. Amali studies there in TMH. Usually, ribociclib almost like before starting the trial, when they analyze the data, most of the almost like 40% of people are on were kept on 4 mg because of the rash, transaminitis, the QT prolongation. What everyone speaks about or talks about in conferences, like it's a very rare instance to be seen, but more of a transaminitis and rash is significant toxicity what we saw before. So that's why like they analyzed it and later they made a study. Amali studies going on TMH which will answer this question: 4 mg versus 600 mg. Yeah, are both efficacious, equal efficacious or not? Okay. So maybe that will answer the question what you ask. But as of now, like whatever I have seen, 4 mg, like people whoever maintaining a good response, like they're having a decent response like 600 mg.
So like palbociclib, I think most of our patients tolerate 125 mg. Like hardly we find like few patients.
That's what only elderly people there is a question, but otherwise everyone is like fine.
Yes. Okay.
Okay. With this, we would like to conclude the session. I thank Pfizer again for giving me this wonderful opportunity to interact amongst with the two brilliant doctors. And with this, I hand over to HiDoc team.
Thank you, ma'am.
Just to add, just one point. I thank you, Pfizer, for giving me this opportunity. So it's a privilege. Actually, both of them are my batchmates in my studies, and to meet with them in a meeting like this is actually a privilege to me. Thank you.
Thank you, Pfizer. Thank you, Kripa, ma'am, and thank you, Pradeep. Nice interacting with you.
Yeah. Thank you, doctors. On behalf of Pfizer, I take this opportunity to thank today's moderator for wonderfully moderating the session. Thank you, Dr. Kripa Bajaj, ma'am. I also thank the expert panel, Dr. Rajni Priya, ma'am, and Dr. Pradeep, sir, for giving in your expert opinions and addressing the virtual attendees why not only the clinical trials, also the real world setting is more equally important to make clinical judgment. Thank you so much. We look forward to hear from you on a virtual scientific platform in the near future as well. I also thank all the attending doctors who have connected to this meeting virtually. Thank you. Have a great weekend.
Thank you.